What's going on, young people? We only have 2 videos left in Unit 8 about clinical psychology, and they're both going to be talking about treatment and therapy. So what we do for folks who have been diagnosed with a disorder, okay? Our goal is still to be on track so that y'all can test on that next digital learning day. So that's what we are aiming for here, okay? We're talking about the history of treatment, how psychologists think about treatment, how you might work in psychology if you want to be involved with treatment and therapy. Then we're going to talk specifically about some psychotherapy, okay? To kind of do some review of some of the main methods of therapy that we've talked about this year. This first slide, there's nothing to write down. I just want y'all to kind of listen, okay? Think about treatment. So about 15% of Americans use some sort of mental health service, meaning get treatment or therapy in a given year. The 2 main reasons they do so are for depression and anxiety. Those are the 2 most common disorders that people go and get help for. Women are more likely to seek help than men. Why might that be? Think about that. We'll talk about it in class. They've found that having insurance greatly increases the likelihood of treatment, meaning if someone's helping you pay for it, you're way more likely to go get it. We'll talk about that in class. And then this is interesting. The Surgeon General, meaning America's main doctor, has said that the biggest reason people don't get treatment is because of the stigma surrounding mental health treatment, meaning the way they think they might be treated or the way they think that people might look at them. Some stereotypes and assumptions people have about treatment. So part of our job needs to be to make sure that folks are getting the help, the support, the therapy, the treatment that they need, okay, and supporting them as they do so. So now we're going to dive into notes. So Roman numeral 1, the history of treatment. So the first thing that people used to do back in the day is called trephining. Any idea what trephining is? Take a look at the pictures over here. Might be a little hint for you. Trephining, they would drill holes into people's skulls if they were acting strangely. They said so that the demons and evil spirits could be removed, right? Back in the day, the main form of treatment was like spiritual, dealing with demonic forces, exorcisms, okay? For much of human history, this is what people believed would make people act strangely, and therefore they would try and release the spirits, okay? Philippe Pinel was the first person who really started talking about mental health in terms of science, okay? So he was French and he was a reformer. So it's the first bold term for you to write down. Philippe Pinel, right? The French version of Philip. He said that, you know what? Maybe there are other things besides spiritual forces at work, making people act strangely. So a woman in the United States named Dorothy Dix, circle her name, put a star by it, underline it. She was sort of the first American who said, we need to have more humane ways to treat people. Right? She said that the mental institutions back in the day, where they basically just lock you up if you were acting strangely, she said those institutions need to be fixed, reformed, changed, shut down. De-institutionalization, shutting down these really bad, unhealthy mental hospitals. And what she said, and what others have said, like Philippe Pinel, is that the treatment of psychological disorders should be more like medical treatment. The way that we treat people who have a physical illness, right? We should help support people the same way when they have a psychological illness, okay? If someone has a broken arm or a broken leg or the flu, we don't just say like, hey, like, you shouldn't have gotten that. Or like, hey, get over it. I'm sure your arm's fine. But when people have a mental illness, a psychological illness, people often say things like, oh, it's all in your head. You need to get over it. Just deal with it. It's not that big a deal. Or like, don't be depressed anymore. We need to treat mental health the way we treat other forms of medicine. We call this the medical model. And we talked about this in our reading on the first day of the unit, but the idea of the medical model is that mental disorders, there's a reason for them, something in the body. They can be diagnosed and they can be treated. Those are the 3 ideas of the medical model. And we talked in the previous unit about how different people, the way that they develop disorders is because of their diathesis, meaning it's because of their nature, right? Their genetics, what they've inherited from their folks, the fact that we are all humans, that we do not have perfect DNA. But part of the reason why we develop these illnesses is our diathesis, our nature. And part of the reason we develop things is because of the stresses in our lives, our nurture, things in our specific environment or experiences that we have. So you might have 2 twins, identical twins that have the exact same DNA and genome, but only one develops a mental illness. Why? Well, maybe that particular twin has had some different experiences or environments since conception that have impacted the way their brain and body have developed. The diathesis stress model. is the idea that your surroundings play an impact on your likelihood of developing an illness, right? And in fact, sometimes you might develop more than one illness. We call this comorbidity. You have multiple bad things. This was also in that reading, but just make sure that you have that phrase down in your notes. Some people have multiple disorders, like we talked about in our last video, people who have multiple personality disorders, who may be diagnosed with depression and anxiety, or schizophrenia and another disorder, comorbidity. So let's say you want to get involved in helping folks out, right? You want to be involved in treatment and therapy. Well, there are 3 different levels of prevention, meaning 3 different levels of care. Primary care is like trying to prevent people from getting a disorder, okay? So like if you know someone who might be at risk of something, right? Teenagers, y'all's life is hard between school and like unnatural sleeping patterns, and you're so busy with sports and clubs and activities, and you have hormones and stresses and relationships and teachers that you're dealing with. Well, primary prevention is like, let's try and prevent teens from having an anxiety disorder or developing a depressive disorder, right? So teaching teens how to regulate their emotions might be a good way of doing that. Or like if we have an adult that we know is at risk of, I don't know, maybe depression because it runs in their families, we can work with them ahead of time on strategies to take care of their thinking, their cognition, and their behaviors, right? Primary prevention. If you go to get like an annual physical, we call that primary care for your physical body, right? You're not sick, you're just getting checkups and getting tools and skills to make sure that you don't get sick, that you are taking care of yourself along the way. Primary prevention for psychological disorders is kind of making sure that you're taking care of yourself along the way. Secondary prevention is like, okay, you have developed some sort of a psychological illness. What do we do for you now? So you've experienced a trauma or a crisis and you need counseling, right? Or maybe you're showing signs of problematic eating tendencies, and we want to try and diagnose and treat and get you help immediately so that this disorder does not become a long-lasting problem that snowballs. Now, for some folks, they develop a psychological disorder that is long-lasting, right? Maybe it's a form of substance abuse disorder or anxiety or schizophrenia, right? Some of these disorders, they never really go away. So the 3rd level of prevention, tertiary prevention, is when we try and help you live as normal a life as you can. You're going to have this disorder, right? People say that once you're an alcoholic, you're always an alcoholic. Once you're an addict, you're always an addict. If you have schizophrenia, we don't have a cure for that. But what we can do is help you live with these symptoms, okay? That's the 3rd, the tertiary level of prevention. Think to yourself, if you're going to work in the psychology world, which level of prevention would you want to work in? Would you want to help people with strategies for staying healthy? Would you want to help them respond to developing illnesses? Or when people have these lifelong psychological disorders, would you want to help them deal with those symptoms and manage them throughout the course of their life? I'll be interested to hear about that from you in class. Similarly, if you wanted to work in the psychology professions, what type of work would you want to do? So if you want to be a counselor or therapist, you're gonna have to get a master's degree after your bachelor's degree. So you go to college for your undergrad degree, diploma, but then you're gonna have to go to a little extra school to get a license. You have to have a couple years of experience shadowing someone. And these folks usually kind of help people with not super severe disorders, but who like are close to being able to live a normal life and just need a little support, a little help, thinking through some things, maybe some strategies. We call this problems of normal living. This is what my mother does. She's an LPC, a licensed professional counselor. Okay, she's a therapist. Now, if you want to do a little bit more than that, you could become a psychologist. This would typically require you to get your PhD, your doctorate degree. This allows you to diagnose folks, to interpret inventories. This requires like an internship, and then you can decide whether you want to be a clinical psychologist working in a hospital or clinic, a counseling psychologist doing what a therapist does, but being able to diagnose and administer tests, a little bit extra stuff. Or if you want to be a research psychologist doing experiments and studies to learn more about how you can help folks. One step up from being a psychologist is being a psychiatrist. Now remember, I've said all year, a psychiatrist, they can get you high. Psychiatrist, meaning they're the only type of psychology professional who can prescribe drugs because they don't have a PhD, they have what's called an MD. They've gone to medical school to get their doctorate. So they've done a residency, they've done a medical internship. It's like the highest paying and most complex and complicated because these folks are the ones who are not just diagnosing, but also treating with drugs, okay? And doing some of the same things that psychologists and counselors might do. So these careers kind of build off each other. Now, if you're interested in helping support folks and you don't want to do, 10 years of school after high school, you can still be a social worker. That's in the psychology field. You could be a nurse. You could work in a psychiatric hospital. You could be a school counselor. There are other professions that are still helping folks out that you can look into. Okay. Quick check for understanding for you. See if you can answer these questions without your notes and make sure that you understand these things. I'll give you just a few seconds before we move on to the next part of our notes. All right, we'll go over these in class together. I want to spend these last two slides just kind of talking about a little bit of review of the basic forms of therapy and treatment. Okay, so Roman numeral 5, let's talk about psychodynamic therapy. So everything up here, all these bullet points should be a review for you, right? When you see this phrase, psychodynamic or psychoanalytic, you should be thinking about Freudian psychology with an emphasis on the childhood, right? Early development. You should be thinking about the unconscious. So remember, Freud's whole theory is that your personality, your issues, and his big focus was on anxiety, right? So that's what he was all concerned about. Those defense mechanisms that help you cope with and deal with anxiety, that comes about because the selfish part of you, the id, and the good rule following part of you, the morals, the superego, those are trying to balance, but they're in tension. And that's what we see of you, the ego. Okay, so we talked about the 5 psychosexual stages: oral, anal, phallic, latent, genital, right? Owls always play late games. So these are the things that we associate with Freud. Free association, letting people just talk and talk and talk, and eventually they'll share something, they'll reveal something about their unconscious, subconscious. Dream analysis, Freud's idea that what people dream about reveals their unconscious desires and motives. Projective tests like the Rorschach, where you tell a story, you tell a tale about an image or a picture, and that's supposed to reveal something about yourself. So all this should be reviewed, but when you see these terms, it's about psychodynamic therapy. So 2 other phrases I want to make sure you understand. So the first idea is Freud says that a lot of anxiety comes from the fact that we don't want to acknowledge the problems, the conflicts deep down within us. So when someone's starting therapy, starting counseling, they often will resist, meaning they will either just like ignore it or regress or repress or act the opposite of how they feel, or they might just be silent. They might not even want to talk to their counselor or therapist. So that's a Freudian idea. There's resistance initially when you're doing therapy. Another Freudian idea is called transference. You may want to circle this point. There will be questions on the test about transference. But to transfer, what the idea is, Freud says that if you are frustrated by your relationship with your parents or your boss, what you might actually do is you might treat the therapist the way you feel about these important people in your spouse, like a parent, a spouse, etc. Some therapists will say that this is a good thing, almost like a acting out role play, where treat the therapist, say to the therapist what you would want to say to your boss, your mom, your husband, your wife. And Freud said that this allowed the patients to really understand their deep down feelings and to move on from their hurt, from their frustration, from their problems. Okay, so it's an interesting Freudian idea. Treat the therapist like the person you have problems with. Transfer your feelings. It's almost a form of projection, but towards the therapist so that you can resolve those feelings. The last bullet point, also a little bit of review, kind of related, when we're talking about psychotherapy, is Carl Rogers' idea of what we call client-centered therapy. It's kind of like Freudian in the sense that it involves a relationship between a therapist and a patient. But client-centered therapy has the goal not of like resolving the unconscious. The humanists said, no. Our problems come from the fact that we've not supported each other, that your environments have been broken, your surroundings have messed you up, and therefore we need to support you so that you can self-actualize. The way that we do this is by not a therapist should not judge their patient, their client. What does UPR stand for? Unconditional positive regard, right? We've talked about this already. There's a focus for Carl Rogers on empathy. This idea that by feeling what the patient, what the client is feeling, it'll help them grow their self-concept so they can have congruence, and then that's what will allow them to get better. So the other phrase, a new phrase that came about through this client-centered therapy, is active listening. Making sure the therapist, the counselor, is really echoing or mirroring what the client is saying. So if the client says, I'm frustrated, I want to run away, the therapist won't repeat back word for word, you are frustrated and want to run away. but they might rephrase what the client is saying. I hear you saying that you are angry and you want to escape. They're not using word for word, but what they're doing is acknowledging that they get what the client is saying. And they found that this allows the client to feel like they are being heard and understood, and that feeling of support actually can help them move through their process and move up Maslow's hierarchy towards self-actualization. So kind of like Freudian psychotherapy, but humanist therapy from Carl Rogers, client-centered therapy. It's another form of treatment, okay? In our next class, our last class, we'll be talking about some of the other forms of treatment. We'll be talking about medications. We'll be talking about the behaviorist approach. And we'll kind of wrap up by talking about those alternative treatments. But make sure that you can answer these 4 questions about the psychodynamic and humanist therapy. We'll talk more about these in class, okay? Appreciate it. Have a good one.